So what we often do is this. This is how we use the likelihood ratios. We essentially take a pretest probability, right? We have a suspicion that the patient has a disease. That's what the pretest probability is. And then we then look at the numbers on the left-hand column here in the middle, where it says 1,000, 500, 200, 150. And we draw a line between that number and what the likelihood ratio is of that test. And that'll carry us through to the other side, which is the post-test probability, which then tells me, well, how much did that test change my opinion? Did it increase since they tested positive, did it increase the likelihood that they actually had the disease because they tested positive or not? And again, these are features of the disease testing itself. Similarly, we can take that same point, draw a line through the numbers here that are less than 1, where it's out with 0.5, 0.2, 0.1, 0.05. And through that same point, if a negative test is there, it'll tell us how much did it lower our expectation of the disease, and is it actually enough to exclude the disease? So here's an example of that. So we're taking an example of that we have a pretest probability of 30%, right? So there's at least a 1 in 3 chance that I think the patient may have the disease. I'm going to run a test. So the first test is this black line here. So that's a test I ran. And that test result makes no difference, right? So this may be a test where I ask a question, is their favorite color blue? And their favorite color blue has nothing to do with if they're having a heart attack or not. And so therefore their post-test probability is the same as it was the pre-test, because the test was a useless test. So a useless test has a likelihood ratio of 1. Even if we double that and make the likelihood ratio 2, the 30% risk improves to maybe a 45%, right? So it hasn't really changed my mind that much. It hasn't even pushed me past a 50-50 role yet. So that information is only considered to be supportive. It's not diagnostic, right? So likelihood ratio 2 is not very good. Once we get to a likelihood ratio of 10, that's kind of like a rule of thumb of where we begin to diagnose, say that things are approaching a diagnostic level of testing capability. And so, this person who we have an assumption is, may have a 30% chance of having disease. Well, you can see here in the end, it increases the likelihood to 80%, right? So at 80%, I may have a threshold to begin treating somebody. I may not, but if the treatment is severe and harsh, we may want it to be even higher. And you as a patient may want it to be much higher than that. But that doesn't necessarily mean we can achieve that. Because we're only limited to the tests that we actually have available to us. So, so those 3 numbers here, 30%, you've got a likelihood ratio 1 gets you to 30%, a likelihood ratio 2 gets you to 50%, likelihood ratio 10 gets you to 80%. So those can be plotted onto a graph. And again, I don't want to lose you here, but this is an important graph to understand because it affects the way that we think about diagnostic tests. And so here in this graph, you've got that first test, that crappy test, test number 1, which is the black line. It's uninformative, and it's basically what the pretest probability is at the bottom here, the bottom axis, and your likelihood that you have the disease is in the y-axis. And they're unaffected when a test is crappy like this. The teal line here is a positive ratio of 2, and that's supportive. So that zone is kind of a supportive zone, but not really diagnostic until you get up until this kind of light pink color where you begin to see that. And so based on these different pretest probabilities, you can see these curves begin to separate more and more and more from each other. And this is important because it helps you choose which test do you want to use. And the ones that are curved furthest away are the most informative tests. But they may have features where they're more expensive. They may be more burdensome, right? They may require a surgical sampling from a patient. There's a whole bunch of different things that occur that kind of affect these likelihood ratios that may make it impractical to choose a test that's fantastic and choose a lesser test because it's more affordable or it's more available. But when you look at these curves, it gets really easy to just get kind of frustrated by the rainbow of colors that are there. But the thing I want to draw your attention to is that early on, when we're in a country with a low disease prevalence, the pre-test probability is the likelihood of having a disease. And so here, we're in this bottom left lower hand corner. And in that left lower hand corner, there is something where that occurs that is important for us to really understand. And that is, at a specific pre-test probability in the lower sides of this, there's very little difference between a shitty test and a great test. So I've kind of given a mark here at about 5% pre-test probability. So that's kind of representing what we think, currently, our local areas may have a 5% infectious rate with COVID-19. And a test that's completely useless, which is the black line, is there. And the difference between that and the supportive line only increases your post-test likelihood to 10%. And a fantastic test only increases it to 35%. So again, you're not even getting past a 50-50 mark here. And when you're doing this as a surveillance of a community, this can, again, seed some distrust, because you don't see those curves truly begin to separate until you get out to 20% and 30%, where you begin seeing those numbers really differ dramatically from each other in terms of what information they're providing you. And so I don't think I can stress enough like how important it is to understand that in a low prevalence state, these likelihood ratios don't discriminate. And that's really an important feature here. They don't discriminate very well. And so that lack of discrimination continues to add to confusion. And so we're early on in a disease process that is going to continue to challenge us until the disease prevalence increases enough and our surveillance and understanding increases enough that we can begin to discriminate and differentiate between different patterns of disease, risks, and treatments, and so on and so forth. And so right now, there's a lot of vagueness in our medical management and decision-making because of this. And even if we had the greatest tests available to us, that would still be a problem based on this tight portion of the corner that we all start off with in an emerging disease. All right. So what are the consequences? In using a PCR test that has a high specificity and moderate sensitivity, there are a few false positives. All right, so that's what we've seen with the initial PCR tests, is that they're highly specific, and so there's few false positives that are seen, but there are many false negatives that occur. And the consequence of that is that a patient returns home or to work capable of spreading the disease because they believe they're susceptible when in fact they're infected. And they're infectious, to those people that they're going to come into contact with. So that's been the problem with our initial testing strategies with this, right? So in particular with the initial tests that we got from the CDC, but even the tests that have followed that, they haven't had such great sensitivity that we avoided false negatives. So we've had to understand that if the patient's symptomatic from a clinical perspective, it could be bacterial pneumonia, it could be a viral seasonal pneumonia, it could be a bunch of different things, but it could still be COVID. And so it's important to understand that consequence. That's a very different consequence than what occurs with serology testing, right? The serology testing is looking for the presence of antibodies. So, and these tests have both a moderate specificity and low to moderate sensitivities, depending upon which test is coming out from whom. And these can be filled with many false positives and false negatives. But the consequences are different than they were for PCR. The consequence of a false positive is a patient returns home thinking they've recovered when they're still vulnerable. Whereas a false negative results in a patient returning home thinking they're vulnerable when in fact they've recovered, right? So these consequences are quite different than the infectious consequences. So if we want to reduce the risks of infection and we're trying to focus on that risk, that profile is important to understand with how we're going to continue to look at PCR testing and or other forms of active disease testing as opposed to post-disease assessment and antibody presence. They're two very different strategies, and there's so much focus on that we're doing any testing whatsoever that that's lost and missed. And it's also important to understand that just because a test has poor sensitivity, it doesn't mean that it's not useful. And I'll get to that. So